for another virtual global spine conference. I'm Wendy Gibbs, and we're so excited to have Dr. Maziyar Kalani, who's one of my colleagues at the Mayo Clinic in Arizona. Dr. Kalani did his training at Cleveland Clinic and before that at Stanford. And he's a spine surgeon, neurosurgeon, specializing in spine oncology. And it actually was meeting him when I was interviewing at Mayo that was one of the reasons I went there. He's doing such great work. So we're very excited to have him talk about some of the new tools and techniques in dealing with spinous metastatic disease. So we also have our co-host, Dr. Ali Baj. Soon we're going to have Dr. Nader Dadale and Dr. John Shin. We've got Koi Tan. We've got Jonathan Razzulli. And then we also have our great new panelists, Dr. Mike Galgano. We might have Dr. Mike Selby soon, Matt Goodwin, and Alex Mamagani. That's a lot of names. And Aaron. Thanks, Aaron. All right, so with that, why don't we have Maz go ahead and share your screen, and we'll get started. And Dr. Kalani is going to kind of give a presentation, and we'll stop along the way to ask questions. Our panelists, our co-hosts, and also in the chat. Go ahead and answer your question or ask your questions, and I'll pass them along as we go.
Cool. Thank you very much for the kind introduction. I think half of the nice things about me probably aren't real, but I appreciate them. So my talk today is on surgical innovations in metastatic disease and multidisciplinary management. Kind of sounds like a weird title, but what I hope to really get across is that what we do in spinal metastatic disease is inherently very multidisciplinary. And so when thinking about how to approach metastatic disease, this goes beyond just the things that we as surgeons think about, but also aspects of the care that our oncology colleagues, our radiation oncology colleagues, and our interventional radiology colleagues who are also involved in the paradigm of care for patients with spinal metastatic disease are going to be involved in. Before I go, everybody can see this okay, correct? Yeah, perfect, okay. These, sorry, click here. These are my disclosures, consulting for these three companies. So the important surgical themes for the management of spinal metastatic disease are threefold. One is radiolucency, fatigue resistance, and spinal oncology. The reason for these is radiolucency is very important for post-operative planning. Very rarely do we perform any kind of surgical intervention for patients with spinal metastatic disease where we're not going to be addressing their post-operative course with some level of radiation. The radiation is very much dependent on the ability for the radiation oncologist to be able to see what they're doing. And as a result, to be able to actually adjust the dosing in order to be able to not give too little, not give too much radiation, to be able to exclude areas of the anatomy in order to protect them, such as the spinal cord. Fatigue resistance is important because depending on the type of pathology that we're dealing, the quality and the efficacy of the systemic therapy may delineate a much longer lifespan for some of these patients, and therefore the issues around maintenance of mechanical stability and long-term hardware stability and durability becomes very important. And of course, in a lot of these folks, we're dealing with functionally osteoporotic patients, so the ability for the hardware to hold them very well becomes important. Of course, minimally invasive approaches are becoming more and more relevant in all aspects of spinal care, but in these patients who are generally sicker, the importance of minimal incision, maximal access, minimal disruption of tissue becomes really important. And in the last aspect of this talk, I'm going to talk about a little bit about kind of pushing the boundaries about multi-stage minimally invasive operations that will hopefully afford folks the best of what we are able to offer as surgeons with the least amount of tissue damage, and hopefully as a result, a faster return to their systemic therapy and radiation therapy. So some of the relevant issues that we'll talk about is wound healing. A lot of these folks, by the time we see them, have maybe either gone through radiation already, or because they're planning on going through radiation, wound healing is going to be very important. And the folks who've been radiated before, wound healing becomes of utmost importance. So these large incisions, significant muscle dissection, the issues around healing are very important. So the application of minimally invasive approaches is really relevant to these folks. But of course, there's radiation planning, like we were talking about, dosimetry related to the high Z or high electron content of a lot of these alloys that we currently use becomes really important. If you're dealing with certain types of tumor where recurrence becomes important, one good example is renal cell carcinoma, where the systemic therapy in most cases tends to be so good that recurrence in certain locations becomes important. Being able to evaluate those cases well with imaging and following for tumor recurrence is very relevant. Outside of metastatic disease, it's even more relevant in primary tumors. And of course, maintenance of fixation despite non-union is very relevant. So being able to hold the mechanical integrity of the spine intact, despite knowing that most likely these patients are not going to go on to develop a bony union, becomes really important. So Dr. Gibbs asked that I focus on some of the carbon fiber work that I've done. And as we were talking about earlier, there's, as a surgeon, we tend to see a lot of these folks either in the ED, kind of in their duress, typically from either severe mechanical pain or from compression of their neural elements. But how do we get to see these patients more electively in the clinic? It tends to be referrals from our oncology and our radiation oncology colleagues, and their desires for referring these patients, of course, is to help patients, but there's also elements of their own care that become important in what we're able to afford these patients surgically. In the case of the largest referral source, which is the radiation oncologists, radiolucency becomes very relevant because they want to deliver radiation. They want to be able to see where they're delivering radiation, and they want to be able to see where the spinal cord is for spinal cord protection. Of course, there's secondary iterations in terms of delivering stereotactic body radiotherapy, and of course, proton therapy, where these factors become even more relevant. So fixation despite radiation, as I brought up, a lot of these patients, especially if they've been radiated, their bone marrow really is all fatty. It's not going to have any really good potential for fusion. On the flip side, folks that do end up going through radiation afterwards are probably not going to fuse. There's a more recent case series that got published, I think about a week or two ago in one of the journals, where their long-term fusion rates were south of 40%. So in addition to that, we don't really have any good grafting material that we can use. We can't use BMP in spinal metastatic disease, a relative contraindication. We can't use autograft. So you're really left with things like DBM, things like allograft, which typically don't fuse very well. And as you'll see later, we're in an era where cancer care is getting better and better. We have better immunotherapy, better radiation modalities. Patients are living longer, so we can expect that a large percentage of these patients will go on to fail at their hardware, whether it's at the bone screw interface, at the rod. So the need for the hardware to be able to hold these patients tightly, hold their mechanical integrity effectively, becomes even more important. So instead of potentially revising these patients every year or two, that will, we can maybe kick the bucket down a little bit further, revising every few years. So metal fatigues, we all know this, the strongest metal in the world will break. Even if you take Wolverine and you bend them enough, his adamantium will break. And we see this in metal constructs. So I think the literature reports about a 3 to 7% rate of screw breakage in general. And typically that happens when there is no bony union. And you can see one of the consistent things with all of these images is the non-inner body fixation that folks used to do. These are degenerative cases, so they're not that relevant, but the aspect of non-union is very relevant in the spinal metastatic population. So the desired solution would be to get something that's as strong as metal alloys, but can be well visualized. Something like PEEK, for example. Fortunately, PEEK's not great. And that's beyond kind of the scope of this talk here, but if you can get something that holds things together tightly, lasts longer than metal, but also images better than metal, that would be the best case scenario. One of the issues, however, for radiation, though, is that a lot of high density metals tend to cause scatter. So you can see we've had this evolution through time with very stiff, non-imaging friendly material to composite material. And this is a graph showing kind of what we're looking at in terms of fatigue strength. So the carbon fiber systems are composites; they're not metals. So you can cycle them over and over and over again, and they tend to tolerate the loading quite well. So the typical system will cycle anywhere from 3.5 to 5 million cycles. And carbon fiber typically tends to do much better than that. You can see the average spine generally cycles about 2 to 3 million times in a year. So most systems are designed to be able to tolerate that. And we tend to typically, of course, tell folks that, at least in the degenerative times when we're fusing folks, that the average fusion takes 9 to 16 months. And hopefully by that time you fused and you don't need to cycle your instrumentation anymore. The benefit in the case of patients who undergo radiation, who essentially lose their potential for union, is that hardware that can withstand more cycling should hopefully, at least in some cases, experience less likelihood of fatigue and wear. This is probably most relevant in our day-to-day lives and travel. You can see in certain countries, if you've ever been in the Middle East or certain other third world countries, they're using airplanes from like the 1960s and 1970s. And the reason behind that is because planes are made out of composites. Composites can withstand a significant amount of cycling through all the different forces that an airplane will undergo. Airplanes in the past, however, were made out of aluminum, were made out of steel, and unfortunately, due to the cycling issues, they either couldn't go far enough or they couldn't be used long enough, because eventually they'll just fall apart. So nowadays, we're seeing planes that are made essentially of what a lot of these carbon fiber technologies are made of: carbon fiber reinforced thicker polymer. So in this case, we're using PEEK. So this is what it looks like as far as imaging goes. So not only do we have good fatigue resistance, we also have really crisp imaging. And the imaging becomes really relevant because once you get your post-operative MRI and then you fuse it with your post-operative CT, which is what this is, the images are very crisp. The radiation oncologist can see the spinal cord. They can exclude the spinal cord. Any residual disease that's no longer in the epidural space that needs to be highlighted and contoured by the physicists and the radiation oncologist can be done so very easily. And as a result, the radiation can be delivered hopefully with lower doses without any kind of significant spinal cord injury from it. This is kind of what
Can I stop you for 1 second? I apologize. It took me a second to unmute. I was going to try to get into that natural applies. I wanted people just to appreciate these images for 1 more minute, because anybody, I mean, for me as a radiologist, this is just miraculous seeing these images, because what we're used to is all the streak. You can't see anything on CT or MRI usually. So, I mean, having this tool for us even is just amazing to be able to see in the canal. And if at the end there's any time, I'll show one of my pictures just comparing, again, the MRI, you know, without this and with, because it's just, to me, it's an amazing advance, not just, you know, all the fatigue resistance and everything else, but just this appearance is absolutely amazing. So that's why I was pausing so everybody could just appreciate it for 1 more minute.
Yeah, and I actually included this slide here. You probably think, like, why did you just jump over? I included this slide because there is a relevance to the type of MRI that you use. I think most folks with titanium will use CT myelography. You know, there is still some trace amounts of titanium within these. The benefit, I think, of the titanium coating, as you'll see later, is you can, you know, for most of us who are used to seeing where our screws are going, it's nice to see that. It's nice to see where your screws are going, but it does cause some artifact when you're using a 3 Tesla MR as opposed to a 1.5 Tesla MR. But you can see it's still very crisp. This is a separation surgery. I think this was the very, very first case I did. You can see a little bit of the instrumentation there, but basically enough room between the tumor and the cord for our folks here to be happy to perform SBRT on. You good? Can I continue?
Yes, please do. Unless
Yeah.
anybody has any questions at this point, since we've got to stop. Does anybody have any questions? Matt Goodwin. All right.
Yeah, of course, you know I was going to speak up. So Dr. Kalani, that's great.
Interrupt. I think it's much more fun when it's interactive. Go ahead.
And I'm gonna have to step off in a minute. I apologize, but so I have not started using any of these. I flirt with it a lot. We talk about it a lot. We have meetings and such. But I'm a dinosaur, and I like using things that I have lots of data on, I feel comfortable with and can perfect. So I use titanium and CT myelograms, for staging and stuff. And MRIs. What is it that convinces people like me to start using it, who have not been convinced? Is it in your experience? Is it that the data are good enough now that you're not seeing as much of the fracture of the implant? Is it, I'm just curious to know what it is that you think changes the game for people that are going, I don't know, I haven't used this much, I'm not sure about that.
Yeah, a great question. So of course, this stuff hasn't been around long enough to have all of those nuances of, does this affect your dosimetry? Does it affect, the quality for the patients to not have to undergo a myelogram? Some of these things that we would typically look at. So far, I can tell you anecdotally, we've done maybe like 5 or 6 young women with breast cancer who are alive over 2 years out. We haven't seen any union in any of them on CT scans, and we have seen 0 clinical complaints of mechanical pain. Now, do you see that with titanium? Absolutely. So it's overall, it's a little early to tell. I can tell you just from personal experience that it has been very helpful in terms of engaging our radiation oncology colleagues, in terms of referring a lot of these patients earlier. Again, anecdote, but I can tell you that nobody in our practice has done a post-radiation compression fracture with cord compression in the last 2 years. I mean, we're seeing these referred early. We're seeing them referred before radiation. So wound healing has been, has not been an issue for many of these patients, and late radiation complications have not been a significant issue. So I think that's been a really good aspect of this. It's that it's been probably better for patients, but we haven't done this long enough to have any good data to share in terms of that.
Well, this is great. I think a lot of us are close. I think some of us are scarred by PEEK and some of the other things. So thanks for showing some of this. Look forward to seeing more of this.
Yeah, absolutely. Anybody else? All right, cool. I'll keep going. Please feel free to jump in if you have anything to say. I think, again, it's more fun when it's interactive. So showed you this. And so this is kind of what we're looking at. So when someone can visualize the canal very easily, there's none of the starburst artifact. It's a lot easier to delineate where you're delivering your doses, where your drop-offs are in terms of radiation planning. This becomes even more relevant when you're doing proton beam therapy. A lot of times when we get these outside referrals, we have the fortune of having a proton beam here. We tend to see a lot of patients who've been operated on the outside come here, and our radiation oncology colleagues are typically asking either, do you know what's in there and what the titanium alloy composition is so that we can adjust our proton beam curves better, our Bragg's peak, or can you replace what's in there with carbon fiber so that we don't actually have to do anything in terms of dose adjustments? And so, when you're talking about cord protection, having your Bragg's peak, pushed over to the left for lower dosing, this is also really helpful. So the lower the Z, the lower the density of the metal, the easier it is to deliver lower doses. This is what the system that I've been using looks like in vivo in a real patient. It's a top-loading system. A lot of that is, I think, limited by the manufacturing capabilities in order to design a system that is not pressed molded, but rather fiber strands of carbon fiber, which can usually tolerate a significantly higher level of disruption. It has a titanium shell, which again, for those of us who like to see the instrumentation, at least some, this is kind of what it looks like. So when you're looking at some of the cases that I show a little bit further on, you can kind of see what you should be looking for. The last little plug for why there may be some benefit, again, none of this has been really studied in case series just because it hasn't been out long enough, is that the modulus tends to be the closest to normal cortical bone. So it does have some flexibility in terms of stress sharing and stress loading. So a couple cases, again, maybe what I'll do is I will go through the case, show the pre-ops, and kind of see what folks would do. And none of these cases are super complex. None of them are like, look at what I did, look how cool I am. They're just some of the cases that I've done that I think the imaging represents the utility of the technology. So I have a 50-year-old lady, very cachectic, had presented with mechanical back pain, but was neurologically intact, had some lesions found in her, had some pulmonary lesions, and in the process of getting a CT scan, there was concern for metastatic disease at T8. She had pulmonary effusion. She had bony metastases, not a lot of solid organ disease other than the pulmonary issues, but she was very thin, very cachectic. She had this on her preoperative imaging. You can see this mediastinal disease there. So grade either 2 versus 3 epidural cord compression, just to keep it interactive. Anybody want to say what they would do for this?
Hey Maz, it's John. How you doing?
Hey, what's up, man?
Great to see you. Hey, I joined a little late, but I first of all, I just wanted to say thanks for hanging out with us tonight in this venue. And I'm just gonna make one point, and I'll be quiet. I think this case is great because it illustrates how at different centers you may treat this differently. I would argue this is if you were at MD Anderson, this is something that Claudio Tatsui may treat with lit. For a patient that's cachectic, maybe frail, with that degree of epidural disease, just a consideration. So before everyone else is going to chime in, but I'm just going to throw that out there that I think that sometimes it's affected by what you have at your institution.
Absolutely. I have no experience with lit. I'll be upfront about that. So yeah.
All right, who else can hear? So maybe Goodwin, before he has to jump off, do you want to weigh in on this?
Yeah, sure. This is a patient you said with no metastatic disease. Is that correct?
Known metastatic breast cancer.
Okay, so I don't from this cut, I don't think I see any other lesions here. Am I?
Yeah, correct. That's
yeah.
The
So
solitary spine met.
yeah. So I guess to add to John's point, a lot of these, I think, emphasizing the point that multidisciplinary care is the future and how most of us function, I think is really important. And I think a lot of us, sorry about that. So, for, in this case, this, I'd want this to be, biopsied because I don't, this is the only, and I'd want to image the whole spine before we got too far down the road here.
I'll tell you, she got a tap, and her pleural effusion was positive for cells that were consistent with her primary breast diagnosis.
So she has a pleural effusion. She's how old?
50. She's quite young.
Do we know anything about the radiation status of the patient? Has that area been radiated before? I may have missed that.
No, she had not been radiated.
Yeah, I mean, I think there are a couple strategies, right? I mean, one is this patient is neurologically intact, you said?
Neurologically intact, yes,
Yeah,
correct.
I mean, I think you can make the arguments, obviously there's a lot to consider, her response to systemic therapies, if any, to this point, the receptor type of her breast cancer. I think all things considered, we're primarily looking at the radiographic imaging. I mean, I think you could do this through a, separation surgery technique, intralesional decompression with the thought of following with some type of adjuvant, radiation, whatever you have at your institution. Because I don't think, I don't know. I think in the metastatic setting, it'd be a pretty big deal to go after that large paravertebral lesion unless, her functional status could really justify that.
Wait, let me call on Mike Selby if he can unmute. I don't know if he can, but Mike Selby, your case that you posted on Twitter this morning was a bit like this, kind of, with some relevant differences. Are you able to talk or no? We'll see if he can. You might not be able to. All right, well, go on, Mazi. Go ahead and finish what you were going to say.
Yeah, so we did this kind of as Dr. Shin suggested, as an intralesional tumor separation surgery with fixation above and below. What I didn't include and what you would see with a CT scan is actually the entire vertebral body had been essentially replaced. There was a very quite a lytic lesion at this point. I did not go after the mediastinal mass. So purely just a separation, decompression off the cord. We used a peak strut to reconstruct the anterior column. You can see basically the imaging is quite crisp. So from the point of view of getting post-operative treatment here, you can see that the canal is very easily imageable. You can see the spinal cord. You can see the separation. This tends to make out, at least our radiation oncologists, quite happy, and it helps with their management after we are done. So there's another case. This one is a 61-year-old gentleman with pancreatic cancer to T3 at an outside facility. He underwent a unilateral T3 transpedicular decompression, came over to our institution with a complaint of unsteadiness, difficulty walking, and left leg weakness. He had a SIN score of 13 and complained of mechanical back pain. And he had metastatic disease to the liver. He was otherwise actually pretty well and healthy. And this is his preoperative image. You can see that maybe there was a pseudomeningocele or something that was contained, grade 3 disease, significant disease over here on the left. I think this is the transpedicular decompression that they had performed. Still a significant amount of disease circumferentially around the cord. Any takers for this one?
Hey, Nader, do you do these kind of cases at Northwestern?
Yeah, absolutely. We do. We treat metastatic spinal disease too. Yeah, I mean, first of all, check the boxes. This prognosis obviously should have good functional status before we deem to another operation. Definitely incomplete decompression, and got to go back in and resect the compressive component and stabilize posteriorly. Now, putting a cage or not, it depends on. Well, got to get a CT. If it's really lytic, then surely you can reconstruct the anterior column. But definitely to go back in and revise it and complete the decompression so that so that radiation would be feasible, because it's too stuck to the spinal cord. You got to separate it a little bit, give some more room around the spinal cord, and stabilize it dorsally.
Yeah, that's pretty much kind of what I did. I was a little hesitant given that he'd had surgery and concerns about his functional status, but he was still quite healthy. I think he was biking like 50 miles a week despite his disease status. So he's taking pretty good care of himself. So at the request of our radiation oncology colleagues, we did exactly that. And I mean, you can kind of tell we did something up here, but that's the beauty of the imaging, is that it's really hard to see. I opted for a short segment stabilization in the back. This area between the sternum, the clavicle, there's just so much rigidity in that part of the spine. I didn't think we needed to necessarily do a rather large separation, fixation, but the imaging worked out very well. He unfortunately has since passed due to the natural progression, natural history of his metastatic pancreatic cancer. This last one is a cervical case. I think everyone's kind of seen the screws and the pedicle screws and rods for posterior fixation, but there's applications for ventral, for cervical cases. So this one was a 65-year-old lady.
Maz, this is Ali. I apologize. Sorry for interrupting. Can I ask a question about that last case?
Yeah.
First of all, I think carbon fiber screws aren't good for social media, because you can't show these pretty X-rays with the hardware and everything. So you're gonna have to figure out a way so we can show our beautiful X-rays, right? Because you're right, you can barely see that anything is done. But on a more serious note, you know, you're obviously at an excellent institution, very close by to where we are. I want to pick your brain a little bit about what that multidisciplinary consultation process looks like at a place like Mayo Scottsdale. So this patient with advanced pancreatic cancer, metastases to the liver, what does that process look like for you guys? Are you obviously the radiation oncologist called you about it, but are you getting the patient's oncologist involved? Are you pressing them to give you a prognosis? Do you in your institution, in your spine program or neurosurgical program, have a general consensus like, hey, 3 months, 6 months? You know, to me, that patient there suggested that they may have a very poor prognosis, right? With metastatic pancreatic cancer. So we're not second guessing what you did. I mean, that's a doctor-patient issue. But what does that process look like at your institution in terms of getting all of the key players on board to determine whether to operate or not, and what the extent of surgery should be?
Yeah, again, fantastic questions. So we are in the process of formalizing our spine tumor board here. So it'll be a process that's more formalized, sit down, everybody at the same location. But right now, the way it looks is that we tend to talk with, so every evaluation is done individually between the oncologist, the radiation oncologist, and one of us. It tends to be a decision between all three parties. And of course, at every institution, every oncologist thinks that their patient can live years, even with diseases like metastatic pancreatic cancer. We tend to define the patients that we're going to operate on with a KPS of better than 70 or 80. And we tend to try to shoot for a life expectancy of greater than 3 months. I think that's probably what most folks do. I think that if you borrow a lot from the Patchel data, that the quality of life in these patients can be dramatically improved by decompression, stabilization, radiation, that being able to maintain ambulation, maintain continence, truly does affect their overall quality of life. Factoring in that they can live through their healing process, through their therapy process, we tend to, in general, favor the quality of life aspect of treating these patients. How aggressive we are depends on some of the things you brought up. And I think some of the things that I'm going to talk about a little later in the talk reflect some of those issues around prognosis and how we can give them the quality of life without going too crazy with what we do to them and how much healing they're going to need to do and how much rehab they're going to need to do after.
Got it. Thank you. Thank you so much.
Yeah, thank you.
Hey, Maz, can I ask a question?
Yeah, please.
Hey, I know you're going to show a great cervical case, but if you go back one slide on that, I have a question for you. And for full disclosure, I mean, I do use carbon fiber. I do use the system. I've used it quite a bit, and I have found it helpful. And I do agree with you, Maz. I think that one of the issues is that there's not a lot of post-market clinical data coming out of the United States. And that's where questions regarding like dosimetry, cost effectiveness. I think all of these that many have probably asked or will ask in the chat room, I think will come about. I was wondering if you could share and maybe enlighten me a little bit. You know, one of the challenges that I have, and maybe many others here may experience that as well. One of the challenges that I have is determining what type of fixation is going to be good enough or strong enough for these patients to provide that palliative benefit, right? Because I think like on the market now, we've got these carbon fiber screws. We've got these carbon fiber screws with fenestrations that you can augment through. I know that you and I both use that. We also have titanium screws with fenestrations that you can augment through. There are also vendors that have expandable titanium pedicle screws, you know, where you don't use cement, but the pedicle literally, the screw literally expands within the vertebral body. So on a practical level, I was just wondering, can you share some insight in terms of like, do you have a way of assessing the bone density, or is that sort of a game time decision after you put the first screw, you know, like if you're going to augment that? I don't know. I struggle with that. So I'm curious to hear what your experience is.
Yeah, I mean, I'm with you. I think it's kind of, I try not to make any of these game time decisions just because I'm a little leery with just how healthy these patients are with doing more to them. So I have augmented where I felt that the purchase isn't very good. This specific case, he had actually been radiated. So a lot of the folks who come after they've been radiated tend to have sclerotic bone, which tends to make it a little bit easier to make a decision as far as where to fixate, how much above or below. But I agree, you know, in certain cases where they appear lytic enough, what I've tried to do once in a while is in situ, I'll try to cement the end plate at the levels above and below and try to put in, again, imaging friendly anterior column support. So usually like PEEK to try to be able to give it a little bit more structural support, a little more anterior load sharing with the posterior instrumentation. But I mean, you nailed it. There's no real great way to figure that out. Really, those are the two things. If they've been radiated and their bone seems sclerotic, that helps a little bit, at least for me, in terms of decision making. And then the other one is really CT scan before surgery to see how much disease is involved. Of course, the real nightmares are the widely metastatic mixed lytic blastic breast mets, thyroid mets, but luckily I haven't had too many of those.
Yeah, no, that's
Hey,
great.
Maz, it's
Oh, sorry. Go ahead.
hey Maz, it's Koi. Thanks
Hey,
for your
man.
talk so far. Hey, quick question, and sorry if you addressed this, but you know, you mentioned this patient previously irradiated. In these types of cases, do you tend to prophylactically engage plastic surgeons, or sort of what's your threshold for getting them on board?
Yeah, so
I know we use them a lot here at Duke.
yeah, I have. I did in this case. It ended up being quite, so the tissue seemed vascularized enough as I was doing the case. And one of the other reasons to go a little bit shorter segment on this is I was worried about wound healing. But we do, especially on the revisions, we do get them involved. But earlier I was saying one of the nice things about what we've been doing in terms of the prioritization of separation and fixation is that a lot of these folks end up getting operated on before they get radiated. So generally speaking, we're dealing with actually pretty good and tissue environment for healing. So in that sense, it's been really helpful.
Maz, I just have one follow-up. You know, I have a case recently that where I used this system, a carbon fiber system, for a very similar type image. I think a little bit lower down, maybe T8 or some. So, and it's the only situation where I actually have to revise it because he's developed sort of kyphosis within the construct. You know, sort of like they had a path fracture. You know, I did 2 up, 2 down, stabilized it, but then, you know, the distal screws came out and the kyphosis worsened. And clearly, you know, when I look at it, you know, I don't see it as a failure of the system per se, but he has just very weak bone. And I think biomechanically, you know, I wonder whether I should have augmented there, you know. But it's one of these scenarios where I don't think much has been published on sort of revision strategies or looking at how to deal with these systems when maybe they sort of fall apart for whatever reason afterwards. So I have it coming up. I'll definitely let you know. But I was wondering if you've had any situations where you've had to go in and revise any of the hardware or connect to it. Can you shed some light on that?
And not yet. In full disclosure, a lot of these patients have gone on to pass. So the ones that we're keeping an ongoing database, the ones, of course, that are alive, the ones with good immunotherapy options, the younger patients, especially the young breast mets. I've been following them out longer than the typical year. I follow most of like the degenerative patients. And so far, I haven't really seen a whole lot of issues with instrumentation. One of the things interesting to your point is a lot of these folks, after they've gone on to get radiated, it seems like they actually sclerose really well around the instrumentation. But to the other point, I have yet to need to add or go up or down from what I've done. So again, I think that's a numbers issue. Just haven't had that volume.
Maz, I have a very basic question for you. How are you checking these screws intraoperatively? Are you using some type of 3D reconstruction, or are you just going by plain x-rays?
I do an O-arm spin to check placement. Cool. So I'll go to the last carbon fiber case. So this is a case I did a few months back. 65-year-old lady, widely metastatic melanoma, immunotherapy resistant. So to Dr. Baj's point about prognosis, this lady was probably one of the sicker patients I've treated. She was myelopathic, very weak, had a lot of mechanical neck pain, had a SIN score within the probably unstable range. Again, this was definitely a multidisciplinary engagement. Her oncologist thought that she had a good 6 months to live despite her disease status, but overall her functional status was probably on the lower side. She had this presenting MRI, T2 on the left with cord compression. The epidural disease is better delineated on the contrast scan. And a good amount of her disease, probably should have included the axials, was really behind C6. So we opted to treat this with an expandable peak cage. The manufacturing capability of being able to do the screws with carbon fiber is not quite there yet, as far as I understand. So they still use titanium screws to put those in. And the cage is a little bit thicker. Again, I think that's all due to really manufacturing capability. But overall, really good fixation, really good decompression, and good separation with this case. Got all the tumor off of the spinal cord in the front. So with that, so that's another option, probably less commonly done, but overall the imaging is very good. I would imagine that this is probably a really good use of the technology in a lot of the primary diseases that involve the cervical column. So again, really only done one case with this, so not a whole lot of experience to tell you guys, but other than that, it's for the most part practically just like doing a standard corpectomy or standard ACDF with the carbon fiber instrumentation. The one limitation I should add is that I don't think any carbon fiber system exists that has been able to manufacture lateral mass screw size. So I think as far as I understand, the manufacturing capability is kind of limited to 4.5 or 5.5 millimeters. So 3.5 screws, 3.5 rods. Those are kind of not quite there yet. So this is kind of what we're limited to. Any kind of posterior fixation would typically likely require standard titanium instrumentation. But if you're dealing with mostly anterior column disease, this still can be quite helpful in terms of limiting the amount of scatter that you get from your circumferential decompression and stabilization.
Question. I have a question, Maz. Sorry.
No, go ahead. My question is a little bit more random about the imaging. So go ahead and ask yours first.
So obviously this patient was radiated post-op, correct?
I believe so, yes.
Okay. Thank you.
Was that your only question? Okay, then I'll go. Molly, this is a question for you when you're evaluating it before even surgery. That MRI you showed was pretty dramatic, and yet if you saw this CT, you wouldn't even know they had cancer. So you're talking about the quality of the bone making a difference for your choices. What is this? Is this sclerotic? Is it lytic? What's from the CT? I don't know if I could tell you.
I couldn't tell you either, but I did get a preoperative CT, and this is what I saw, and I was impressed. So with specifically these cases, so not every case I do is with carbon fiber. I think maybe that might be a takeaway from this talk, that maybe everything I do is carbon fiber. Of course, that's not the case. So some of these are attempting to push the boundaries in the safest way possible for the specific patient. And in this case, the limitation is drives a lot of the decision making. But when I saw this, really the only amount of bony involvement was at C6. It really, the rest of the bone looked pretty darn good. And I know you've given us some talks about using CT as kind of like a poor man's bone density scan in the past. So I looked at this and thought, probably for the purposes of fixation in a patient who isn't going to be living years, the bone quality is probably adequate to have them go through this.
That's very interesting. And, I'm hoping Dr. Mamagani, he's the expert here on this panel on bone density and osteoporosis. I don't know necessarily with cancer, although that's part of it as well. And I hope someday he'll address that with us because he knows way more than I do about it. But before, I want you to talk in just a second, Alex, but let me ask you one more question before I forget. Mazi, I asked you once, can this be used in kids? We had a young patient who was a cancer patient who would need to be followed for a long, long time because the prognosis was very good. And I'm just wondering if you can share your answer. If this was like a 16-year-old with they needed extensive instrumentation, but they were going to have a long life. Would that be something you would attempt with carbon fiber? Sorry, and not cervical spine necessarily.
In general, yeah, no, I think that's like the best patient population to use it on. I can tell you, I have a good friend who's a pediatric neurosurgeon in Switzerland, and for a lot of the cases that he does, a lot of the myelomeningocele or some of the more complex spina bifida patients that he takes care of, in his words, when I send these out to the pediatric orthopedic surgeons, it's kind of understood that they're going to be putting in carbon fiber technology to be able to follow these patients long term. So I would imagine that that's like the best group of patients to do this on.
That's great. Alex, were you going to add something there too about bone quality or even your experience? Because you said that you have carbon fiber as well that you're using.
Yeah, hello, Mass. Great talk. It's a really impressive cases. But I think it's a little clear for me that on different parts, different countries, tumor surgery is different. So the last two cases in Switzerland, we have tumor boards. We do it interdisciplinary. We were talking a lot about technique tonight, but these cases would be treated differently in Switzerland, I guess, due to indication, because I think pancreatic cancer, melanoma is really hard to treat. Our population is perhaps a little bit different to US Americans, and the wishes and the life quality of our patients, I guess, there would be a great consensus in our tumor boards and the patients as well that we would not do these kinds of surgeries in these patients. This is different, I think, from country to country, from individual to individual. And for me, I would choose these kind of surgery as a surgeon. But maybe I would not recommend it to my patients. It's really difficult, and it's great to hear that in different parts of the world, tumor surgery is completely different. The first case, for example, would be the same here in Switzerland. The second and the third would be different. And from the technology, I think when you look at bicycle, at going by bike, everything goes carbon, and we don't use the old technology. If you want to be really on top, if you want to be in front running new technology, I think carbon will replace a lot of titanium and old metal implants in the future, not only in spine surgery, as well in extremities. My colleagues from orthopedic, from femur, from shoulder, and all the other parts are looking for carbon solutions as well. I think it's really nice to learn from your cases. I think it's the future we were seeing here.
Thank you. Like I said, I think the mistake as far as the takeaway from this talk is that this is kind of, a lot of these cases are trying to push the boundaries a little bit to try to do something a little bit more unique. Of course, don't want to practice on patients. None of these are particularly unique in that regard, but they are interesting as far as guiding their post-operative care, and they're interesting and down the road in terms of figuring out, will these effectively make a difference in their care? So,
hey Maz, this is cervical. It's a great case. I think that these are challenging, and I think the reconstruction looks really great. So I think that's really impressive. The question I have is, what's your strategy for filling the cage? I think we all can acknowledge that it's a very difficult arthrodesis environment, but I'm wondering, I've gone back and forth. Sometimes I put cement in there, but then sometimes that counteracts the benefit of the carbon fiber, versus DBX or cancellous bone. I'm just curious, what do you use, and do you brace these patients post-op?
Yeah, a great question. Again, there's probably some administrator with an Excel sheet that hates me because I do put it. I deep down, I probably don't think these guys will really go on to heal, to fuse, but I still, I'm pretty aggressive about using biologics, about using DBX, et cetera, even sometimes cell-based therapies that don't have any kind of contraindications in cancer. But I mean, the truth is probably cement or just the cheapest DBX that you can find is probably adequate, just so you have something to hopefully bridge it over. But I don't think anyone's holding their breath for most of these patients to fuse.
No, I agree. Hey, Galgano, Mike, how about you? What do you do in your practice?
Yeah, I've got a bit of experience with using bioglass in these type of cases. So I think it's maybe commercially known as NovaBone, but you can use the bioglass. Has some reasonable data around fusion, but it's also got some data about gets a bit alkaline when it's in the body, and it can inhibit infection as well, which is a real issue with these patients. So I've been using bioglass the last couple of years, and it's been working quite well.
Cool. That's good to know.
Hey, Maz, I know we have only a few minutes left, but since we kind of broached that subject, speaking of administrators with spreadsheets, can you comment on whether you think this is a cost-effective technology, and how do you address that? How do we address that into kind of areas either within the country or outside of the country, throughout the world, that where access to technology could be an issue? What do you think about that?
I mean, I think in terms of cost effectiveness, we address, value is, price over quality. So in that regard, I think you have to define your patient population pretty well. I think in terms of our practice here, it has helped build our practice, grow our practice. So in that sense, I think one would argue that it is a worthwhile expense to be able to build the practice and build the volume. I think the way you can answer some of those cost effectiveness, value-based questions really revolves around studying these longitudinally to see if it does affect their overall care. Does it affect your return to OR for wound dehiscence and wound infection? Does it affect your dosimetry and complications related to doses of radiation? So we don't really know those. And so it's a little tough to define value very well. I think it's probably a lot easier to define it in primary tumors and patients where You're going to be following them long term. They're going to stay alive, hopefully, for many years, and their revision rates become relevant in terms of the overall cost of care for the specific disease. So a lot, I think in metastatic disease, that may be a little bit more challenging to answer. I think if you break it down by population, overall, if you take the return to OR for any kind of hardware related revision, especially as patients live longer, if you're indeed able to reduce the number of necessary revisions in that patient's lifetime, I would argue that absolutely, there's definitely a cost benefit in that regard. If you're doing it for some of these other patients where we're really kind of pushing the bar, pancreatic cancer, immunotherapy resistant melanoma, probably not. But in a better defined population, that becomes relevant. The other part is what does radiation oncology look like 5-10 years down the road? Are we going to have a proton beam in every 3 or 4 in every city? Are we going to be treating these more and more with all types of metastatic disease with proton beam? If that's the case, then the density of what you put in your patient becomes relevant, and whether we're using titanium or not, that'll factor in. And of course, there's economies of scale. If we're dealing with this as the mainstay of treatment and even degenerative cases, and your manufacturing becomes 10, 100, 1,000-fold, you're probably going to make these a lot cheaper, and it's going to probably be more accessible to folks in other countries and other institutions as well.
Yeah, that's so hard to define, what is value. And I think that, at least in our experience since, introducing this technology in Boston, one of the things when we plan for postoperative stereotactic radiosurgery, oftentimes, our standard pathway is to get a CT myelogram on all these patients. And so if you can imagine for a cancer patient to bring them back, 2 to 3 weeks after surgery, when they still have incisional pain, whatnot, then coordinate interventional radiology procedure, with neuroradiology, to have another intervention when there's a lot going on. Is there cost associated with that? I'm sure there is. Is there some aspect to the patient experience that relate to that? I'm sure there is too. So I think it's hard to quantify. We haven't really done that yet, but it's using the carbon fiber implants for those patients that we know are going to have SRS afterwards. It's sort of helped eliminate that one step. But I can't say whether that's really truly cost effective though. I don't know.
Maz, I have a question. I know we're almost done with this session. First of all, fantastic cases, and I learned a lot. So when you see those patients in follow-up, you get imaging, correct? Like X-rays?
Yes.
And what you're looking at, probably alignment, but probably it will be challenging to diagnose a rod fracture or a screw fracture in those with these carbon fiber implants. What's your take on that?
Yeah, so I'm getting standard X-rays on them for weight-bearing X-rays for alignment, but the patients in general, our oncologists and radiation oncologists have significant imaging protocols where a lot of these patients are getting multiple CTs as part of their standard oncology follow-up. So we're seeing those pretty well in all those images. And I think the one case I was mentioning about patients, especially the younger patients who undergo radiation, in their downstream CT scans, you can actually see that the sclerotic bone tends to hold these really well. That's mostly comes from the anecdote of looking at these images downstream that these patients get just as part of their oncology workup.
Actually, can I throw in something there too, just from the radiology point of view? It's easier for us to find screw fractures actually on X-ray than on CT, or at least for me. I think that's most. With these carbon fiber screws, a lot of times, you don't even know they're, unless you are looking at the chart, sometimes you don't even know they're there. We don't have a good history, which we do, I think, where we are. But a lot of places, if you didn't know that was the history, you wouldn't even see them. It would be very hard to find the breaks. You'd be looking for the alignment. It is interesting to me that you would have to go to CT to look for hardware failure, because that definitely, from a radiology point, that is harder. Maybe from your point, because that's what you're looking at, all the time, that it's easier for you. But I do think that post-operative imaging for the canal, for any recurrent disease, for epidural disease, anything else, it's so much easier. But other than changes in alignment, looking for that, any breaks in those screws is going to be much harder. That was all. That was my comment. I don't know if you agree with that, Mazi.
Yeah, I mean, even if they have broken instrumentation, the main question I always have for these folks is, how's your back pain? And because that's, if you have a fracture in your instrumentation and they're clinically in pain, then that's probably more likely that you're going to do something to it. But if they're not having pain, even if they have fractured instrumentation, I think most of us would probably not really do anything anyway. So,
yeah, that was going to be my follow-up question. If you had one and there's no loss of alignment, would you do anything anyway? Yeah,
yeah.
All right, well, that's great. Well, if there are any last questions, we're actually over the hour now, but if not, let's turn it over. Do we have Coy Dan here? Coy, do you have a speaker for next week? Maybe not. Is Coy here? Okay, well, Coy is going to present, or he's having somebody do something. But Mazi, thank you so much, Dr. Kalani from Mayo Clinic in Arizona. That was fascinating. And again,
Hey guys.
Such a, oh, there he is. Okay,
Sorry.
Go ahead.
I believe next week's my partner and my boss, Chris Shaffrey. So that should be a great session.
On what, Coy?
Spinal deformity.
Okay, that's very vague. Thank you. All right. All right, great. Well, everybody, thank you so much for joining us. Dr. Kalani, thank you so much. And I'm sure there'll be more questions. We'll pass them along to you and in the future, if that's okay. And we appreciate you coming. Hope you'll come on again. Until next week, we'll see everybody.
Thank you. Thanks for inviting me.
Great talk.
Take care, everybody. Bye.